is about one of my main field of interest, that is type 3 macular neovascularization. Here my disclosure, I have no relevant financial disclosure related to this talk. So you know that type 3 macular neovascularization is a peculiar finding of neovascular MD, and it should be considered as something apart in the spectrum of neovessels due to the different origin. You know that type 1 and 2 macular neovascularization developed from the choriocapillaris. On the other hand, type 3 started from the intraretinal circulation. And this is a very frequent event in the neovascular MD. This is the second frequent form of macular neovascularization, secondary only to type 1, accounting for about 35% of cases of neovascular MD in Caucasian patients. You know that this is a very aggressive form of neovessel. If you arrive late in the diagnosis and if you start late with the treatment, the long-term prognosis is very poor. But on the other hand, if you are able to perform an early diagnosis and so a prompt treatment, you can have good results with anti-VEGF injections. For this reason, in this scenario, it's very important to try to characterize the different biomarkers and precursors that could help us to perform an early diagnosis. Some years ago in this multi-center publication, we described this nascent type 3 macular neovascularization. What is nascent type 3? I would like to show you a case. This is a patient affected by an early form of exudative type 3 macular neovascularization. You can see here the hyperreflective lesion connecting using OCTA the deep capillary plexus to the RP and sub-RP space, and you can see exudation in terms of small intraretinal cystic spaces and thickening of the neuroretina. But what happened before? If we go back before the diagnosis of exudation, we perform a structural OCT before any kind of treatment, before the diagnosis of exudative type 3 macular neovascularization, and we detected this hyperreflective focus. Many of us usually describe this hyperreflective focus and interpreted this hyperreflective focus as a pigment migration from the RP. But probably there is not always only pigment. If we perform OCT angiography, you can see that there is a flow inside with this small neovascular tuft using en-face OCT angiography. So this is a non-exudative stage of type 3 macular neovascularization, as we have better characterized in this paper on progress in retinal and eye research this year. But which is the progression starting from the non-exudative stage to the exudative stage of type 3 macular neovascularization, and this progression characterizes the nascent type 3 MNV. Usually, this small non-exudative stage of type 3 macular neovascularization started from the deep capillary plexus and grow down to the RP and the sub-RP space. You can see here the progression during the time, the neovascularization that go down to the RP and sub-RP space. And this contact is very important because only when there is the contact between the intraretinal neovascularization and the RP, sub-RP space, it will be the development of an exudative form of type 3. Some of you can say me, okay, if there is always this progression, you can start the treatment in this stage before the development of exudation. But unfortunately, this is not always true, because in some cases, this non-exudative type 3 macular neovascularization could completely regress without any kind of treatment. This is a case, a patient affected by non-exudative type 3 macular neovascularization. You can see the intraretinal localization of the neovascularization with no contact with the RP and no exudation in this time. And we followed only this patient with no treatment. And you can see that 1 year later, more than 1 year later, there was the complete regression of the lesion with the development of another type 3, exudative type 3, very close to the first one. And this is a real regression, because if we perform dye angiography, so this is not an artifact, because if we perform dye angiography, you can see that at the baseline there was this non-exudative type 3 macular neovascularization, and after that, after more than 1 year, you can see the complete regression and disappearance of the first lesion with the development of another type 3, exudative type 3 macular neovascularization. But from a clinical point of view, it is very important to understand which is the timing between the non-exudative stage and the exudative stage of type 3 macular neovascularization. And in order to try to answer to this question, we perform another study involving, including the fellow eye of patients affected by unilateral type 3 macular neovascularization. Because you know from this study of Larry and Nuzzi of 2006 that up to 100% of fellow eye of patients affected by unilateral type 3 macular neovascularization will develop a type 3 in the fellow eye in the 3-year follow-up. And in this new study, we included, for this reason, the fellow eye of patients affected by exudative type 3 macular neovascularization in the first eye. First of all, we confirmed the high incidence and prevalence of type 3 in the fellow eye, about 80% of cases in our series with 3-year follow-up. But the most important thing is that in more than 70% of cases that will develop an exudative form of type 3 macular neovascularization, they were characterized by a non-exudative stage about 8-9 months before the development of exudation. This is very important from a clinical point of view, because if you are able to detect the non-exudative stage using OCT angiography, you can change your follow-up, you can follow strictly your patients, because you know that this patient is characterized by high risk of development of exudative type 3, especially in the first year. And what about nascent geographic atrophy? Nascent geographic atrophy is a structural OCT finding. You know that this was described the first time about 9 years ago by the group of Robin Geimer in this publication. It was associated with the development of geographic atrophy starting from a drusen regression. It is characterized by the loss of the outer nuclear layer with the subsidence of the outer plexiform and internuclear layer, and this hypertransmission effect below the drusen due to the RP rarefaction. But yet at that time, Professor Querques wrote a letter underlying as this kind of sign could be not specific only to the development of geographic atrophy, but it could be associated, for example, to the development of a type 3 macular neovascularization. And in order to try to answer to this question, we perform a new study that we have published this year, involving again 6 different centers worldwide. And we included patients with an exudative type 3 macular neovascularization, but with a serial structural OCT before the development of exudation for at least 2 years. Among this population of included eyes, 97 eyes, we characterized that in 22 cases there was the development of a nascent geographic atrophy stage before the development of an exudative type 3 macular neovascularization, and this accounted for an estimated prevalence of about 23% of cases. I would like to show you one case of our series. This is a patient affected by drusen at the baseline. At this time point, this patient developed nascent geographic atrophy. You can see the loss of the outer nuclear layer, the subsidence of the outer plexiform and inner nuclear layer with this hypertransmission effect below the drusen. And after that, the patient developed also a nascent type 3 macular neovascularization and the progression of the neovascularization to the RP and sub-RP space, and after that, the development of an exudative type 3 macular neovascularization. Again, from a clinical point of view, it is very important, the timing. The mean time between the drusen stage and the development of a nascent geographic atrophy is very variable. So it is not very useful from a clinical point of view. But the mean time between the nascent geographic atrophy stage and the development of an exudative type 3 macular neovascularization is about 9-10 months. So in this multimodal imaging era, using structural OCT, OCT angiography, we are able now to characterize biomarkers and precursors of the early stages of type 3 macular neovascularization. We have seen that using OCT angiography, we are able to characterize this nascent type 3 macular neovascularization that precedes the development of an exudative form of type 3 in about 73% of cases, with a mean interval of 8-9 months. Using structural OCT, we are able to characterize nascent geographic atrophy that precedes the development of exudative type 3 macular neovascularization in about 23% of cases. And using these biomarkers, we can change our approach in this kind of patient, we are able to characterize the high-risk patients that will develop probably an exudative form of type 3 macular neovascularization. We can change the follow-up and we can start the treatment in the early stages of exudative type 3 macular neovascularization. I would like to thank all the co-workers involved in this publication, and I would like to thank you for your kind attention.
Very interesting talk. Thank you so much. Thank you so much for this interesting talk. So I have a question about these high-risk patients. How do you recommend to screen or treat them even earlier? Should they come every month, or what do you recommend?
Yeah, usually when we characterize this kind of patient, when we see this nascent type 3, non-exudative stage of type 3 or nascent GA, we follow very strictly at the beginning, between 1 to 2 months in the first year, because we have seen that in a high proportion of this kind of patient, probably there is a conversion to an exudative form. It is very useful to also characterize the intermediate MD stage, because you know that usually patients that will develop type 3 macular neovascularization are affected by combined reticular pseudodrusen and regressing drusen or something like that. So you can characterize, before of all, the intermediate MD stage. You can screen well this kind of patient with structural OCT and OCT angiography in all the follow-ups, and you can change your follow-up when there is the development of this high-risk lesion.
Thank you. Also for me, fantastic talk, and thank you for all the work, because I think it's a highly underdiagnosed lesion, and I think it's very important that you do all this work. My question is, I think coming from different countries, and I would be interested in what is your strategy with fluorescent angiography, because I come from an institution where it was used a lot, and now it's used less. So do you do it in every patient that is exudative the first time? Or?
In our clinic, we perform everything to everybody, but for research aim. But now, especially in this kind of patient, you can use structural OCT and OCT angiography with no FA or ICGA if you have no doubt about the diagnosis. If you have any kind of doubt, you can perform, of course, FA and ICGA.
Any questions from the audience? Yeah, please.
Thank you for a very interesting talk. Sonja Manning from Rotterdam. Is there any value in preemptive treatment at the nascent stage, or any evidence for that?
We don't know. There is only one clinical trial that demonstrated that in quiescent, non-exudative type 1 macular neovascularization, there is no value of preventive treatment before the conversion to exudative type 1. As I've told before, in some cases you have the complete regression of non-exudative type 3 without any kind of treatment. So for this reason, we don't start with the treatment in this stage. But sometimes when there is this downgrowth progression, and when the intraretinal neovascularization go to the RP and sub-RP space, we start the treatment also with no great exudation, only with small cystic spaces. Yeah. But there is no evidence about it.
Thanks very much for a very useful talk. I sometimes struggle to diagnose these type 3 lesions in a patient who's diabetic and has microaneurysms. Can you maybe guide me about how to distinguish between a microaneurysm and a type 3?
Yeah, this kind of, we have also characterized patients with very similar diseases, not diabetic, but PVAC, for example, that is very close to the microaneurysms in diabetic patients. And the lesion, we have published a couple of images, and the aspect is different in the structural OCT. Because in nascent type 3, you don't have the wall, you have a homogeneous lesion with no wall. On the other hand, in the microaneurysms or PVAC, you have this wall very close to the small lesion. It's not always easy to perform that, but this could drive your diagnosis. The second important thing is that you need to follow your patients. In this kind, nascent type 3 usually progress down. There is an extension down from the deep capillary plexus to the RP and sub-RP space, and this usually doesn't happen in microaneurysms, of course. But it's not easy sometimes.
Thanks.
Thank you so much. So I think it's time to move on to the next speaker. Then.
Thank you very much.
It will be Saskia van Romunde, and she will talk about surgical treatment for exudative AMD. Thank you.
Thank you. Thank you for the invitation.